Hi guys, welcome to special edition of COSI Talks Live. We are at the Global Collaborative Conference of Osseointegration, also known as GECCO, here in Charlotte, North Carolina. And I am here with an amazing colleague that I've had the chance to really get to talk to during this conference, Kristin Reeves. So guys, it's going to be a short, sweet episode, but we're going to pack in a lot of information, and I really want you to hear all the work that Kristin has been doing with osseointegration patients. So this is my time where I just do a snippet, and I'm going to have Kristin tell us a little bit about herself.
Yeah, so my name is Kristin Reeves. As Kosi said, I work at TIRR Memorial Hermann in Houston, Texas. I've actually been a therapist for a lot of years, but 27 of them I've been strictly with limb loss. And over the last 4 or 5 years, since osseointegration was FDA approved, that's kind of been my wheelhouse, and really focusing on treating those patients and seeing if we can just elevate them and get them as functional as possible. And as this new novel approach has been gaining traction.
Absolutely. Hey, Brian, thank you for joining us today, guys. Just as a reminder, I'm broadcasting to Instagram, YouTube, and Facebook, so go find me on those things. So, when osseointegration first became FDA approved in the United States back in 2020, as therapists, we were given a protocol. And that protocol was done by Walter Reed, a big military hospital. Fantastic protocol, right? We all started with that. But let's face it, the protocol was created for, military.
Yep, young, active military, trauma, and and the thing with Walter Reed, they have unlimited resources, so they have unlimited therapy. They have inpatient kind of at their disposal, and that doesn't really work for the civilian sector, where we have limitations with insurance and, different things.
And if it sounds like we're just a teeny bit jealous of that, I know from my end, I'm very jealous sometimes that I don't work in the military sector, because it's a beautiful, what the patient needs, the patient gets.
Yeah.
So, these protocols were created for that environment. So, as civilian therapists, right, you're starting to treat a different population, civilian population, and having to adjust these protocols over the past few years. And this also led to you writing this article that you published this year. So congratulations.
Thank you.
On the PM&R journal. So that is quite the accolades right there. About many of the things that you adjusted, limitations and otherwise, in working with your osseointegration patients. So I want to dive a little bit into that in terms of, what are some of the obstacles that you faced working with osseointegration patients and how you worked around it.
I think the first one was really the unlimited resources that they had, or the unlimited number of visits that they had. So, we have co-pays, we have visit limits, we have deductibles, and those types of things. So trying to kind of take their big protocol and narrow it down to something that we can work with was really the first kind of problem to tackle on things that we could not get rid of, but modify on how that would work better with our sector. So that was really the first thing. The other part of it is after stage 1, there is an allowance to be able to use sockets. That insurance isn't going to pay for a socket for just a couple of months. And so, let's face it, we're not going to put them into a socket. And we don't want any distal impression anyways. And so really kind of managing those expectations with some of our patients and making sure that they are well aware of kind of the time frame between the 2 stages was extremely important.
Yeah, it's interesting that you mentioned that. Of the many viewers that I have who've had osseointegration, very few of them have been able to use a socket in between, and not for any physical reasons, but usually just for insurance wasn't going to cover you.
Yeah, and after the first stage, there's some surgery. Sometimes there's some soft tissue or some surgery that just makes the limb not even appropriate anyways to go back into an old socket. So so that was one of the things. After stage 2, then
we get into the weight bearing side of it.
We get into the weight bearing side of it, yeah. So we've got to make sure that insurance has approved their loading device, and also we need to make sure by that time that insurance has approved the Axor. So that's been a challenge that we have. There you go. So this little dandy is super duper important, because it is the one piece of device that is going to attach the abutment coming out of the limb.
We have toys today, guys. I have toys today.
So we'll open that up, slide that in, close it up, and then that is attached to the prosthesis. So if you don't have this little piece of device, then your leg isn't going to be on. So making sure that insurance has a lot of time to get this approved. There's very, very commonly denials with it. And eventually we have gotten it all approved, but it does take some patience, some additional paperwork and those types of things, and somebody to advocate and help get you through that process. So that could be the challenge.
No, and we were speaking with Dr. Alderete, which, by the way, guys, shameless plug, Dr. Alderete is going to be on the show this Wednesday, another phenomenal surgeon, so you're going to want to tune in then. And he worked as a military doctor and now as a civilian doctor, and he was saying that, yes, in fact, there are insurance hoops to jump through, but not to be afraid of that because, with right preparation, it can be done.
Yeah.
So, having to do that. And then, let's talk a little bit about more the PT side of things. This is where we really got out today. Hey, Donna, thank you for joining in on board. So with regards to things that you've noticed as you're rehabbing your patients with OI, so things like back pain that might occur. Tell us a little bit about that.
Yeah, back pain with having some downtime or if somebody hasn't been walking for quite a while, then your back just isn't conditioned to hold your torso upright. And so when we do get you up and loading, sometimes there's some back pain, and it's usually musculoskeletal pain, that instead of loading for 30 minutes, we may have to cut that down to two times 15 minutes, just to allow those back muscles to kind of condition and to hold you upright. And then eventually after just a week or so of doing that, they usually are conditioned up, and then you can start the loading for 30 minutes as it's indicated or needed. So that's one of the not uncommon things, but it's very manageable.
And then other things such as little pains that might crop up with the distal end, right, as you're walking.
Yeah, so I do make sure that everybody is aware of 3 different types of pain, and 2 of them are okay and they're expected, and so I just want everybody to know that they are expected, and both of them do eventually go away. And the third one is a little bit more concerning. So let's start with the first 2. When you first start loading, what you may feel when you lift your foot up, you may have just an instantaneous pain that goes away. And that's okay. It does go away. I've named it rebound pain. It doesn't really have a name, but that's what I've named it. And so that one does eventually go away. The second one is a little bit further along in the process, especially when you start using those interior muscles. It's almost like a tendonitis, and it's usually in the distal or the far end and the front of your residual limb, because those muscles are now being asked to actually work. So it's been a long time since some of those have worked, depending on how long it's been since your amputation, and those muscles are super happy sometimes. So they need some conditioning and some kind of some special exercises, and maybe some massage or some different things that we can use to combat that. That sometimes goes on a little longer than you would like, but every single patient that I've had, which is about 40, it's all gone away. So it eventually does get there. The third type is the one that is concerning, that if it's like a really stabbing, sharp pain that's when you're standing, then there could be an issue with the implant or the bone or something like that. And that's one that definitely does need to be escalated to somebody, the surgeon, most commonly. So.
And this kind of brings me to the next question is, with all these updates and everything that you've learned from seeing so many patients, this is helping therapists like myself where, I have lots of amputee experience, but I'm starting with my journey with OI patients and learning from everything that you've already done, especially with the pain.
Yeah.
Something that we talk a lot about on the show is understanding the pain, where it's coming from and why it's there, and if it's something that needs to be concerning or not. So where do you see we are being
rehab
told,
symposium?
We are being told that we have to. This is Dr. Well, now I'm gonna embarrass you. Come on. Y'all recognize this guy right here? Yeah, he's been on the show several times, and he's telling me that basically I need to stop yapping and sign off. But okay, he's gone now. He's talking for a few more minutes. But basically getting back to how with these protocols now, we're able to now start educating other clinicians out there as OI starts to go throughout the United States. And hopefully continue working there. So where do you hope that we can take these protocols in the next few years? Where are you rubbing it with here?
Yeah, I think the protocol is going to continue to evolve as the surgical procedure evolves. Timelines are eventually going to change. processes are going to change. And so I think the protocol we have today is going to be different than the protocol we may have next year even. So it's that novel, it's that ever changing, and that's what makes it super exciting.
Yeah, and then the ability to tailor it to each patient, because you said it beautifully earlier, each patient is so unique. And even the patient you're going to have, just when you go home now, it's a very unique case that you're going to have to be able to customize it to that particular patient. All right, guys, this is probably the shortest I've ever spoken, and those of you who watch my show know that this is unheard of for me. But for those of you who joined me just now, thank you so much again. Thank you again to Kristin. You are a wealth of knowledge, and I am so glad to get to know you.
Happy to be
and be able to learn from you as well. Pastor David, thanks for being on here. It's a party whenever you're on board. We got Mark on board as well. Linda, I got to give you guys a quick shout out, and Victor. Guys, if you're able to, this is not my normal streaming time, if you could share this to your Facebook support groups, onto your pages, that would be wonderful. So guys, with that, I'm going to sign off because Dr. Shu's going to come after me again. And I will see you guys next Wednesday, same bat time, same bat channel. God bless, guys.